Finn here. Let's look at Chapter 17, Preparing the Autopsied Body. When you are in professional funeral service practice, you will inevitably come across bodies that have been through an autopsy for various reasons. So learning to restore them does take a little bit of a different skill set. It is more time intensive than an unautopsy. But very quickly you will become proficient at this. We do not get a lot of opportunity here at the college in Miami to do autopsied bodies, but once you're in actual practice, or if you're working in a prep center, you get more than enough experience, I'm sure. So an autopsy is an examination of a dead human body. There are other names for it: necropsy, post-mortem examination, and most commonly when we're referring to something like this, we're talking about a body that has been quote-unquote posted in the vernacular. So if you hear a funeral direction of talking about a body being posted, it is because of the fact it's had an autopsy. And there are two general types. There's the medical or hospital autopsy, and also then the legal or medical legal autopsy. So in general, pathologists prefer usually some embalming done prior to autopsy. I have never seen that in my professional practice, but your books say in some communities this is possible. But realistically, in most of the cases, embalming is not going to happen, especially in the case of a legal autopsy where they obviously don't want you playing with the body prior to their investigation. With some autopsies, family permission is required. That's generally the medical or hospital autopsy, and it limits the extent of the autopsy. So if they only want to do a cranial evacuation, for instance, then the pathologist will only be able to open up the cranium and inspect the brain without doing anything else. A legal autopsy by a medical examiner, that's usually not the case. They will do whatever is necessary to perform their statutory duties. So your embalming report should note if an autopsy has been performed on a body for a variety of reasons. The first is when your body first comes in, you should be filling out some type of care embalming report on every body, as the book says, so that you have an idea of what condition the body is in, but also because you don't want someone to turn around and say, well, it might have happened on your premises, and then you be held liable for it. And a big thing to check here is where are the internal organs. Generally, when you pick up a body, the internal organs will either be placed separately in a bag, and that bag may be on the side of the body. It may be, in cases that I've seen, it is placed within the abdomen and thorax, but you need to know where they are, because if the internal organs are missing, that is a real problem for you, and you need to report the fact that it is missing to the family. Do not let them find out in the future. And logic would denote if you're picking up a body that has been autopsied and you notice that the bag is not there, even if it's the medical examiners, you're going to want to ask so that you will have done due diligence and know that someone just did not misplace things. So with the hospital autopsy, the medical autopsy, permission is obtained from family. And the book gives you a bunch of reasons why family might want to do this, but realistically, it's to confirm the diagnosis of a disease. These are very important teaching tools, so it's not uncommon teaching hospitals that pathology interns and residents will be there, and maybe other first and second years witnessing to see what goes on, how to recognize certain ailments. The legal autopsy is much, for the most part, different. It's there to determine factually cause, manner, and time of death, has evidentiary purposes, and is used for a legal investigation and for court information. Cases that fall under the legal autopsy differ from state to state. Generally, we colloquially refer to this as the dirty dozen, and that is basically any case which the medical examiner or coroner has immediate jurisdiction over. So look for accidents and trauma, stuff like that, and that's what you should be looking for if you're being asked a question about this. There's one important category that I am going to kind of expound a little bit upon, and that is the category of apparent good health. So a fact pattern might be something along the lines of a 22-year-old individual passes away in apparent good health. Would this be under the jurisdiction of the medical examiner? Without any more information, that is potentially something that would fall under the medical examiner's jurisdiction. A person 22 years of age with no other known issues does not normally just die suddenly. However, do not fall into the trap that says, you have a 22-year-old person whose family exhibits history of congenital heart disease, and the 22-year-old has chronic hypertension. because of this, ongoing family issue and passes away, jurisdiction of medical examiner, yes or no? The answer would be no. There is a pre-existing condition that is family-wide. Even though the person is young, that is not really an issue because it's a known problem. So don't fall into that trap just because a person is young that they have to go to the medical examiner. And another thing is that just because you were admitted to the hospital and you die within 24 hours, you also don't automatically go to the medical examiner either. You really have to look at it along the lines of, is something there that triggers the investigation? If it's not part of the dirty dozen, it does not. So some general guidelines for you. There are some things in here that I would debate, but for the most part, understand that if you're going to be asked a question regarding the dirty dozen, it's probably going to be one of these items in the book. So any case in which a pathologist holds a bona fide belief that the death is unexplained and an autopsy's in best interest is a final category and an important one. So for the most part, if there is an unexplainable death and the medical examiner or coroner says, hey, we really need to try to figure this out, that is something they can do, okay? Order and preparation is very simple. Do one thing at a time. Do one thing at a time. When you're injecting, don't do anything else, not even setting features. Do one thing at a time. Saving time will lead to complications in many cases, so just do one thing at a time. You're not going to save a heck of a lot of time by, trying to double up on things. Cover broken or cut bones. You do not want a parenteral incident by breaking your glove. Wash your gloves often, and the reason being is you don't want to translocate the microbe, something that may be present in one part of the body, you have then passed to something else. Avoid high water pressure when flushing blood and fluids from the table for, again, spraying things everywhere, and continuously aspirate. Drop a autopsy aspirator inside the open cavities and constantly get rid of the fluid. In some cases, I've been known to actually put the water hose inside the thorax. That way, not only am I constantly diluting, but also the aspirator is effectively removing as much as possible. Clamp things off to keep pressure for obvious reasons. Run table water all the time. Anything that gets on the table, you want to get off the table as quickly as possible. Pack everything. And it's important you understand this. Pack all external orifices. So the rectum, the esophagus and trachea, the ears, vagina. In some states, that even means the orifice of the penis. I think Texas is one of those states that views the orifice of the shaft of the penis as something that requires packing. So be aware that at least in the book, the usual place, rectum, and other places we normally do esophagus, trachea, but then also the ears and the vagina. While embalming, soak the calvarium and sternum in a closed container with preservative solution. Generally, that is held to be like cavity fluid. We'll put in there with cavity fluid, and your practitioners locally can teach you the best way to do that. Stronger than average solutions are generally used on autopsied bodies, and we are going to cover this more in other chapters, especially ones coming up like delayed storage and stuff like that. But also, you need to be concerned about dehydration. So just don't automatically run for 5 or 6 bottles of your favorite 36 index fluid just because they've had an autopsy. Use some common sense. Use the proper supplemental solutions, and let your embalming analysis tell you exactly what you need to do. So body may be in rigor, which can cause poor distribution and indicate false firming. That is true. So generally, you want to put some type of tracer, and also the breakdown of the blood. Hemolysis can create an appearance similar to that of dye. So if you were paying attention to filling out your embalming analysis on your initial embalming report page, you will notice those areas that have the pinkness, so you know that that is not a sign of preservation. Frozen fats can also confuse you, false sign of firming. Dye is going to let you know where stuff is going, but remember, dyes will only indicate surface embalming. You're going to use all the different techniques and tools that you have to build up pressure and get best diffusion. So massage, intermittent drainage, clamping of leaking arteries will assist you in making sure that the preservative gets to the deep tissues. So when you're injecting each section, you can control your rates of flow for each section. You can inject at higher rates than you might need for another part of it. You might want to use a wide tube injector to inject both legs at the same exact time. If you notice one leg isn't getting it, turn one off, focus on one at a time. There's so many different ways that you can establish good circulation. Pulsation, intermittent drainage are basically going to be keys that you're going to need to be doing this on an autopsy. And I understand that individual practitioners will do things differently, but realistically, I have done what the book says here with intermittent drainage, clamping things on and off, and then using my machine on pulse, and I've achieved very good effects. It's not necessary to insert drainage devices into the veins. Don't waste your time. Realistically, it's going to drain just nicely. Take the drainage right from the cavity. Drop your autopsy aspirate in there and pick up as much as you can. If you need to get some more out, run a little water in there and fill it up so it aspirates more. So a complete autopsy involves all of the procedures that you see here. The cranial cavity basically takes out the inside of your head. It's, not rocket science here. Eye enucleations gives you a bunch of things that you should probably kind of note card. Glucose levels indicate diabetes, electrolytes can indicate dehydration, ethanol can indicate increase or decrease of alcohol in comparison to blood alcohol level. Realistically, I don't see what the relevancy of that is. Neck organs, okay, you should know most of the stuff from anatomy, where they are. Removal of the tongue called a glossectomy, okay, a glossectomy. This is somewhere else in the book, I believe. And this is an interesting term, a cafe coronary. I remember a student asked me this question, and I had no idea what they were talking about because I hadn't, I just kind of glazed over that in most of my readings of this chapter. And a cafe coronary is a term for choking. So I would definitely note card that because if I missed it, oopsie, that's bad for me in mortuary school. I'm glad it didn't cost me a test question. So thoracic cavity, your upper chest, okay, your abdominal cavity is anything basically below the diaphragm, kind of a rule of thumb. So know where these cavities are. It's very important that you understand when someone's referring to something like this, what it means. And I give you this nice graph here. What is the thorax versus the abdominal versus the pelvic? When someone says abdominal pelvic, what does that mean? Basically a combination of the lower two. The spine has its own cavity, the cranium. And when it refers to a dorsal cavity, it's all of the head and all of the spine. And when we refer to a ventral cavity, it's the entire front of your body. So there are different ways to remove the spinal cord. We're going to see a little bit about this also in tissue donation. But the dorsal ventral is exactly what it sounds like. If it's dorsal, comes out of the back. Ventral, open from within. We would obviously prefer to get it from the front since that's where we are to begin with. Removed from the foramen magnum and a wedge cut from inside the cavity. So partials are exactly that. They do only one item without doing everything. Most often this is done in a hospital setting. Maybe done in the legal setting, but more than likely we're looking at a hospital autopsy. Usually the restriction for this is because the family only gives permission for that one item. A pathologist may or may not tie anything off. So what I would do is, go in there and start looking around before you begin injecting. It might be a good idea to see what they've tied off and what they didn't. So suggested order, and this is kind of a common sense sort of gig. I'm not going to spend a lot of time on it. Reflects a lot of what we've seen so far. Do one thing at a time, and it means that if, I've suggested maybe you want to use a wide tube if you want to kind of get both legs at once. Again, that is a matter of personal preference. That's what I did when I first started embalming. Now that I'm teaching, I generally do not use a wide tube or something like that unless I'm doing like a restricted cervical injection or doing a head freeze. Don't forget your supplemental treatments. That is very important. We're going to see that especially in the tissue and organ donor chapter, is that you're going to have to inject the flaps of the body that were created with by the incision hypodermically using a hypovalve trocar. And make sure that you drain as much of the liquid as possible from the body, especially you don't want to leave water in there. And then afterwards, put in hardening compounds, absorbent agents, etc. It says prepare abdominal and thoracic cavities and neck area, replace viscera and add preservative chemical. It says not recommended, but okay. Treat viscera and then place directly into body cavities, much more recommended, using liberal amounts of hardening compound and fill neck area with saturated cotton. So what we're looking at is with the replacement of viscera, using sheeting or something like that. And generally, and I'll be honest, when I first started embalming as an apprentice, that is what the old school embalmers did. They set it aside in a small box, and we put that box inside the casket prior to cremation or prior to burial. And basically, it accompanied the body everywhere. You run the risk of losing it. So I'm not a big fan of keeping the internal organs separate from the body just for liability issues. But I've had good results doing that, especially early on in my embalming practice. Treating it like we should and placing it back is much more preferred, in my opinion, for, again, liability issues, nothing more than that. Suture very well, dry everything, reattach the calvarium and suture scalp, so you're working on the head basically last. Wash and dry body, glue your incisions, and away you go. And don't forget to fill out that embalming report. You know, you want a record of everything you did. Some embalmers keep a journal. Preparation, read it on your own time. This is an in-depth review of each of those 20 steps. So I'm only going to point out some of the big things that I think I need to mention, because reading these chapters and making your own notes is an integral part of what you should be doing. Only dispose of the body bag or sheeting after you've disinfected properly. We've seen back in the first chapters of the book that we should disinfect anything that comes in, even if we're putting it in storage. You know, a lot of funeral homes kind of cut corners by not spraying stuff down, but you should do that. When disinfecting the cranium, be sure to support the scalp and forehead so you don't form creases. Okay, so you don't form creases. Make note that the book recommends high index fluid or medium index, to which high index fluid has been added. He comments about adding supplemental fluids as the demand of the body requires. So we're looking at using high index fluids, but also using high index at 2%, at 4%, at 6% makes a difference as well. Treat the body because it has been delayed and has issues. Just don't go in there guns blazing is what it comes down to. Common sense. Ideal vessels for use are the left and right common iliac, not the femorals. And the reason being is because generally these things should be staring you in the face. They've evacuated the organs, so you should see everything you need right at the base of the pelvis. If the internal iliac starts leaking, clamp it off. Inject it separately later to ensure proper preservation of the back of the body and buttocks. And you might want to go in with the hypovalve trocar anyways and treat the buttocks separately. If you desire intermittent drainage, it's simple. Find out where the stuff is coming from and grab yourself a nice big set of locking or even dressing hemostats and go in there and clamp it off. And then open it back up. Note the technique used to establish distribution to the foot, massage and rotating the foot medially. There is no set volume or strength to handle the edema and pathologic conditions. Use your best judgment. There's no magic bullet for this. So generally, if you are making a 2 to 2.5% solution using a fast fluid, a high index fluid, you should be pretty good. If you're going to use something that's like a medium index, 18 to 24, you might want to kick it up just a little bit by adding a higher index fluid to it. Vessels must be clamped when using subclavian artery for injection. There's some important ones there: vertebral, internal thoracic, inferior thyroid. And that's because if you don't, they're just going to leak everywhere. So these are branches of that artery. Fluid does not flow easily down an arm when injecting via the axillary artery. Pull the tube out a little. Open that hole up, and you might actually get it where it has to go so it goes right in. If you're going to improve distribution in lower arm and hand, digital pressure on vein. So basically what you're doing is you're building up pressure by shutting the vein down. And very effective technique. I've done it a couple times. 3 options for injecting the head. Basically, it's restricted cervical, injection of each of the common carotid arteries separately, or a Y adapter. Utilize low rate of flow and low pressure. Obviously, if you're doing anything with the face and it's had an enucleation because of the swelling potential, if they've removed the ear, you're going to have to be packing that area so it doesn't leak out later. Finally, we see the term for the removal of the tongue, the glossectomy. Okay, removal of neck organs is a bit more of a formal definition, but generally, if you're referring to a glossectomy, it's removal of the tongue and most of its apparatus attached to it. And note looking at several glands for swelling in the face: the parotid, sublingual, and submaxillary. It's important that you channel your tissues. You channel your tissues with the trocar. So emphasis on the buttocks, breast in the female, shoulder and neck regions. That way you have as much penetration of those deep tissues as possible. You might actually need to cut back the trunk as far as the vertebral column in order to adequately preserve the trunk walls. What that is saying is you might have to take the flaps and cut them away from the ribs even further so you can actually treat everything you need to. So it says in lieu of autopsy gel, cotton, paper towel, strips of sheeting can be placed within the trunk rather than saturate with cavity fluid. Again, that is an acceptable treatment to pack things as it's stated here. For liability reasons, especially where we have some serious issues with this, I generally do not recommend in professional practice you keep the intestines out. Obviously, if you didn't get the intestines back, you'll need to pack them with something. Paint everything with autopsy gel on the inside surface. And if you do not remove the viscera, sheeting should be placed inside and saturated with cavity fluid because you don't want this collapsed portion of the body. So you have to do something. And it gives you ways to do that. Cavity, you might need to suture the anus. To do so, we've done that a couple times for various reasons. And from inside the body, you might actually be able to touch it out. So realize you can just go in there, grab some ligature, and tie it off and be done with needing the suture. Indicate what you did with the viscera, especially if you're going to use an outside container to hold them for funeralization. I am going to digress for just a moment, and reasons why you might want to do that is you might have stuff that does not fit. You see people go, well, wait a minute, it fit prior, why is it not going to fit after? There is some swelling, especially if the person had trauma to the thorax or the abdomen. You might actually have some post-mortem swelling when you are applying the cavity fluid, which makes things a little hard to fit if you have issues with the flaps. So you might have to store some of those items in an outside container. But again, my preference is to put things back in. But indicate what you did with it, where it is. If they're to return to the body, 2 bottles at a minimum of cavity fluid should be mixed and poured over the viscera before the bag is returned. Be sure to cut into the hollow viscera to ensure preservation. Generally, a good practice for that is to grab some sharp-pointed scissors and just go in there and start clipping things rather than hacking with a scalpel. Some embalmers return the viscera without the plastic bag, ensure the viscera soak in cavity fluid for several hours before returning them. Generally, some embalmers under that school of thought will use a 5-gallon container. Put the bag containing the viscera inside there, put in the cavity fluid, stir it all up, so to speak, and then close it off while they embalm. Then when they're done embalming, they return the viscera afterwards. And be sure if you're going to do that second method that you have cut into the hollow viscera. So you put the bag into the container, you've snipped it up with the scissors, you pour in your 2 bottles of cavity fluid, you tie the bag back up a little bit. I know some embalmers who will put the sternum and the calvarium inside that same container so the cavity fluid reacts to all of it. So there are various ways out there professionally you can accomplish this task. And then suture very tightly. That means baseball and locking stitches almost universally. After surface treatment, you'll need to suture everything closed, put the sternum back, coat it with autopsy gel on both sides. Use an autopsy needle or a double S, double curved needle, okay? An S needle, double curved, or an autopsy needle. Those are all names for the same thing. Linen suture cord, and a minimum of 5 strand. Minimum of 5 strand. You want something thick. You want something thick. When pulling the cord to tighten stitches, pull on the thread, not the needle. You don't want the eye to actually cut through the thread. If you've used cotton as a filler, be sure that paper toweling or something is over the cotton, because if you catch it with the needle, you'll end up pulling it through and making your life miserable when it wicks stuff. Before you start suturing everything off, you should bring all 3 flaps together. So the 2 at the abdomen, the 1 in the upper chest, tie one little stitch to kind of put everything together. And so from the shoulder all the way so to the shoulder along one of the branches of the incision to the sternum, up to the shoulder if you desire. There's different ways to do it. Once I've done the locking stitch, I usually start at the area of the lower pelvis and then work my way up and finish a shoulder, and then I suture the other shoulder down. But the main incision, remember, you always start at the level of the pubic symphysis. You start at the most inferior portion of the body. Tie it in place rather than tying a knot. What that means is you tie a knot in the string, you put the needle in, and you pull it through and let the knot hold it. You don't want to do that. What you actually do is push the needle through and then tie your string locked onto the flesh. Knots will pull right through, especially when you're doing something like this. So use a baseball suture. Suture very, very tight. If the suture looks like the lacing pattern of a baseball, it's probably too loose. If the hole made by the thread is not filled by, or the hole made by the needle is not filled by the thread, double up your thread. The idea is the hole should be completely sealed by your ligature. Every 4 or 5 inches, do a locking stitch. If your thread breaks, you're going to have to figure out the best way to proceed. You might have to start from the opening down and tie off. You might be able to resume where you were and go, just do whatever you have to do to fix it. When you tie at the location of the xiphoid process, continue up to the shoulder. So basically you reach to the sternum and then just don't stop there. Continue straight up to finish one of the shoulders. Make sure that you use incision sealing powder to prevent any leakage, especially in the shoulders where that incision might be almost going to the posterior portion of the body. If you have very brittle skin in an autopsy, you might have to use a worm suture. Suturing is much easier in a female. Y incision is made over the breasts. If it's made under, the breast will be in the way and a bit of a hassle for you. So it is made easier. Y is over the breast of a female. When attaching a calvarium, pull the scalp down over the face to prevent forehead. During embalming, you could use a phenol chemical. That's a cautery chemical, carbolic acid. It can be placed in the compress and laid along the autopsy incision to help dry it out. The calvarium should be removed and placed in a plastic bag with cavity fluid or phenol and sit during embalming. Typically, some type of larger Tupperware container about the size of a Cool Whip tub is usually good for a calvarium, usually good for a sternum as well. Or you can do what some embalmers do, like I said, just put it all with the viscera inside of the 5-gallon tub and take it out when you're ready. Arterial solution or blood that is accumulated should be sponged out, aspirated or sponged out. You'll find your aspirator doesn't work too well within the cranial cavity just because usually of the amount of stuff that's there. Walls of the cavity should be painted with gel or dusted with preservative powder, and any absorbent material should be placed in the cavity to absorb liquids that accumulate. So when you are done doing anything you need to do in the head, coat it with gel, pack it with cotton or some other type of absorbent material, and away you go. Some embalmers will place incision seal powder into the foramen magnum to absorb liquids. Some will force a wooden dowel to hold the head steady. I have never had to do that, but that's just me. You should have some notches in the frontal bone in order to help the calvarium stay put. And I've seen it done both ways, and it really just depends on your medical examiner. So I have here, I'm going to draw a line, and this is the top portion, so this is my calvarium. And then I have the bottom portion, which is my skull. And what they're referring to is, in this case, we see that it is a clean edge. When you put it back, it's probably going to slip and slide everywhere. What someone should have done to make your life easy is something like that, so that when you're putting this top portion down, it will lock in place and stay there. Now, that being said, if you're going to be using something shortly called a cal clamp, you're probably going to need to make some holes so that when you put the screw in there, it has a place to go. And you might have to cut those out yourself. So be careful not to break the notches, because the notches are there to help keep things straight for you. So it gives you some different methods by which to hold things down. Read these on your own. I kind of prefer the cal clamps. You can see that they have a screw down the middle, which means you have to have the notch. I usually prefer this over anything else. I'm not a big fan of the drill and wire. That being said, make sure you have a nice power drill so that if you are going to drill, you're not doing it by hand. Adhesive, not usually recommended unless you have cause for it, maybe like an infant or something like that. But for the most part, your cal clamps are going to be happy for you. Plaster of Paris can be used. One of the previous program coordinators was a big fan of plaster of Paris. I have not personally used it. I've also seen several other methods of like some quick drying concrete or some other things to lock your calvarium into place. Whatever floats your boat is really what it comes down to. I have had one instance where I had to use a needle injector with some trauma. Be careful with that, because remember, this is basically a little impact hammer. So every time you crank it down on something, you run the risk of breaking the bone further. But you actually can use a needle injector. And basically, you're just going to crisscross the wires in an X fashion. After you're done putting the calvarium back, some putty, wax, or mastic along the cut line will help kind of fill in gaps. So when you put the skin back, it'll look nice and neat. Mortuary putty is a nice substitute here because once it's there, it will not expand. Incision sealing powder will expand when it gets wet. So be aware that that happens. You cannot use tissue builder as a filler if muscles are missing. It requires something basically to kind of stick to. So if there's no tissue, it does not work. So basically, putty or wax, sometimes mastic is used as another word for putty, are your best choices here. Coat the external areas with gel, okay? Reflect the scalp over the calvarium. Little bit of incision seal powder or mortuary putty along the posterior portion to catch anything that's going to leak back. And then begin sutures on the right and to the left. Keep the hair out of the way. And it says comb it out of the way with water. Use hair. Moisten the hair with liquid soap and comb out of the way at the incision line. Do whatever it takes, but do not get the stuff caught. It looks tacky. Use a autopsy needle, double curved or an S needle. Names for the same thing. Tie the first suture again. No knotting. No knotting. Tie it down. Pull it through the skin and then tie it. Single linen cord is preferred over double because you don't want that big cord standing out anywhere. And 5-strand minimum for anything autopsy related. Inversion sutures made entirely on the surface of the scalp. This is a nice one to use here if you can get proficient with it. If you've done an inversion, only a straight line should be seen, okay? On a bald head, this can be waxed over very easily, covered with glue and then cosmetics applied. If you use a baseball stitch, be sure each one is tightly placed so that no thread is seen. Some embalmers will even use super glue, which has some advantage with brittle skin in infants. After suturing, wash everything. Seal your sutures with surface glue, and some embalmers will even place cotton on the glue. Yeah, I've done that. If air appears to be trapped in the thoracic area, insert a trocar. Draw the air out. Use the button to put it back. Cover the hole. Dress the body in coveralls or cover the structures with plastic. I really can't stress it enough. If you've got autopsies, you should be putting plastic garments on all your autopsy people. That's kind of a no-brainer. And make sure you tape over all of the cloth areas of that Unionol or plastic garment. Definitely use embalming powders to control moisture, mold, and odors. They give you some additional examinations pathologists might do. The cervical vertebrae, usually done when a broken neck is suspected, and they tell you that it's made along the back of the neck above the line where the shirt collar would pass, so that's going to be a problem. Review the treatment to fix it. It's kind of nothing new. Knees, tissue can be taken from the knee area. I have no idea why someone would want to do that, but okay. Just treat it like a wound, pack with compresses, and away you go. Battered child syndrome always results in a complete autopsy. Very, very invasive. External body surface may be incised where bruising is apparent. They actually collect the bruise for evidentiary purposes. I've not seen that very often. Photographs are usually sufficient. But then you'd have to actually treat the incised area as a wound. So correct lacerations and incisions, you're doing a little bit more work, but you would do that on a full-sized body as well. Pulmonary embolism, they may try to trace the origin of an embolism. Incisions are often made along the medial and posterior areas of the legs. Treat as a deep wound. That's all you basically need to know. You know what that means. Be sure you're using appropriate amounts of incision seal powder when suturing long incisions. And definitely you want the big guns. Baseball stitch or locking stitches. Coat the surface of the stitch with glue and then use plastic stockings because like anything to do with long bones, it's probably going to be a leaky problem later on. Overdoses, well, it's kind of business as normal here. There's going to be some scarring, probably bend of the elbow if they've been using needles. You really cannot close the elbow excision by suturing, so you're going to have to get creative. Cover with compresses, apply fresh cotton after you're done, nice and dry. Use a sleeve, plastic wrap, and if you have to, get a stocking, cut the foot off, you made a sleeve, tape everything down. Partials, well, 3 possible procedures, and it kind of walks you through method 1, method 2, method 3. You can kind of know those. It's not, again, it's not something that's rocket science. It needs a lot of time explained. Close the head as you would any normal autopsy if it's just a partial cranial, okay? Drainage is taken on a thoracic autopsy from the inferior vena cava for the lower extremities. Again, they've cut everything out of the chest, so you should be able to see the aorta, the descending aorta, thoracic aorta, and probably the upper portion. You might be able to see, the branches of the arch. So everything should be there for you to look at. I'm just going to kind of jump through these. Lower body injection. Well, it says you could actually use the femorals for method 2. I would try the thoracic aorta first of all. I mean, the biggest pipe that they have, you can just put something huge in there and inject the entire lower body. Really, really nice, rather than making more cuts than you have to. That's just me. After injection, treat any of these thoracic or abdominal autopsies like you would any flaps, etc. With the abdominal, same exact thing. Use the aorta, okay? So everything in your abdomen is gone. And then use the common carotids. So inject the legs via the iliacs if they're there. If not, find whatever is there so you don't have to make additional cuts. Supplemental treatments, business as normal with any other autopsy, and baseball sutures. So there shouldn't be something new in something. Aspiration and cavity fluid injection thorax can be done either through the diaphragm or through the rib cage. If aspiration injection to be done through the external rib cage, this treatment can be done before or after the cavity's been closed. Up to you. General protocols, again, read at home. Big bullet points. Restoration of deceased natural form and color is what we do as a major definition portion of embalming. Majority of restorative work is post-embalming treatment. Accidental deaths usually result from trauma to visible areas, which means we have to fix it. Tissue must be firm and dry for restoration. In addition to trauma, pathologic conditions are still a threat, must be considered, especially when making your judgments regarding chemicals. Expect a great amount of leakage. Use dyes as a tracer. Thank you for your attention. We'll see you in the next one.